I see the purpose of the arts, the Academy of Regenerative Therapies and Science, as being a multidisciplinary, multiple backgrounded group of people who bring different viewpoints, different experiences, different thought processes, different system problems that they have to deal with, depending on what kind of doctor they are. All their patients have common needs. They have patients in pain. They have patients that are degenerating. They have patients that are injured. Bringing those people into one room, having them explain from their use and their applications will be very interesting and educational for the guy who's just coming in for the first time saying, well, I've heard about this, but I don't know whether I want to do it. The idea of those multidisciplines feeding off each other and giving each other confidence. And if somebody has a problem and there's a speaker discussing that topic, they can always approach that speaker. It's a difficult meeting because they have to appeal to the beginners from the very first time. I want to see what it means and what does it do and does that apply to me? And then the group that are partially experienced and want to gain more detail and more expertise, all the way to the people who are already past that line, are in scientifically oriented, trying to get you the actual answers to say what dose is required to gain this outcome. There's something for everybody within the context of the program.
Hello there. In today's episode, I have the Robert Alexander. And first of all, as I'm introducing him, I just want to let you know that he's the one that trained me on everything I know about PRP and regenerative medicine and fat in the early days when I was learning about regenerative medicine around 2007. So Dr. Alexander is an MD as well as the doctor of dentistry. And he is dual board certified in general aesthetic and reconstructive surgery and board certified in regenerative medicine. He is recognized as a top 10 innovator in stem cell medicine and also had authored and contributed to 55 peer-reviewed scientific articles and 15 plus medical textbooks. His CV is too long to even mention. I just want to highlight that. But what I want to highlight is that Dr. Alexander is one of the first doc to be doing regenerative medicine since 1992, before regenerative medicine even became what it is today. So welcome, Dr. Alexander.
Thank you.
In today's episode, I want to ask you, you started in 1992 and incorporating PRP with fat. How did the evolution of adding PRP with fat came about at that time?
In the 80s, it was learning liposuction or lipoaspiration materials. In the late 1980s, we began to use PRP with our flap surgeries and other kind of surgeries. Found wound healing was quicker and the bone healing was quicker, more effective. So the PRP became an agent and we were spraying that into the fatty tissues. We were likewise starting to do much more in the way of grafting of the fat for volumization, for like cheeks and breasts and areas that needed a volume correction. It became obvious that if these cells were so effective within the adipose tissues that I had been working on for a couple of decades, that if we added that to a graft, would it help? And the answer is it increased the volumization, it shortened the time, it changed everything on top of the skin for the vascularity. The pores got smaller, the vascularity got much more even. The idea of this is becoming a longer-term successful graft to make it last longer and quicker was the outcome. So that's why I continued to pursue that. We documented many cases and published some articles on the use of adipose grafts with PRP for retained values. Around 2000, that began to change when Zuck provided us the information that all those little scattered nuclei that were in fat, because fat cells don't cell divide, all those little cells around there were stem and stromal cells. That's when we realized that, okay, now we kind of have a combination of the wound healing tissues, the cells that do the reparative stuff, and the synergistic effects of the platelets, when mixed in there, will provide them all the growth factors and all the cytokines and all the signal materials to start the wound healing process. And the platelets control wound healing probably for the first 2 weeks to 3 weeks. After that, those cells that are both at the site received and the graft, the material that was targeted to the area through ultrasound or otherwise, those cells would then work together to restore, repair, revolumize, and maintain. Revascularization was the key.
You've been doing it for a long time, and now we're in 2026. How has PRP and regenerative medicine evolved now since 1992?
That's a long question. I don't know. You don't need to go back into the 1990s. I'd say regenerative medicine really got its kickstart as recognized ability in probably around 2002 or 3. That's when it really got the most attention. And that's when I got invited to give a talk at a well-known sports medicine group. And they wanted me to talk about PRP, and they were using bone marrow and PRP, which made no sense to me at all. PRP from bone marrow is the same as PRP. It has a few stem stromal cells in it, but not very many compared to the adipose group. Being familiar with both bony tissues and soft tissue, it became clear that these cells were responding with the use of these growth factors. And so, and long story short, they converted over, and then we've written papers and done things on Achilles tendon repairs, et cetera, for healing for tears, et cetera, and found that the PRP works synergistic. And I worked with a man who's probably one of the foremost, I guess would be a good lead, in that Peter Everts. He came from Europe, but was now back in the United States. And that combination, he had the blood derivatives, bone marrow aspirates, bone marrow concentrations, and PRP. He had it nailed. And doing customized products for PRP, we began to use leukocyte-rich, leukocyte-poor, various forms of PRP. And so in the interim, orthobiologics became a knowledgeable thing. About the time you were with me, we were starting to use the term orthobiologics, mostly biocellular, which the biological part was the platelets, the cellular part was those that were derived from the stem stromal cells that found in the extracellular matrix and on the vessel walls. Those are the reparative cells. They have in every tissue in the body with the exception of the cornea and inside of hyaline cartilage. And hyaline cartilage has no vascularity, so it has to live by diffusion and endosteum, those two components. And so it became a natural thing, and orthobiologics then started to take off when more people realized that you could do that. Some people still believe you have an orthobiologic in use of PRP, but that's not true. I mean, I don't identify in that way. It is a healing agent, but it's half the formula, I think. There are cells both at the sites that are damaged and the graft cells that come in that will utilize that PRP together to synergistically try to activate the healing process altogether.
What is your opinion on how doctors can look at regenerative medicine now, and why is it that they need to start thinking about integrating regenerative medicine in their practice?
Let's go backward just a little bit in your question, and I see the purpose of the arts, the Academy of Regenerative Therapies and Science, as being a multidisciplinary, multiple backgrounded group of people who bring different viewpoints, different experiences, different thought processes, different system problems that they have to deal with depending on what kind of doctor they are. All their patients have common needs. They have patients in pain. They have patients that are degenerating. They have patients that are injured. And those things would be ideally managed without invasive surgery. I think anybody who wants to deal in some degree pain management, but in the inflammatory and immune responses, that's the forte of these cells groups, the reparative cells. And so I think that bringing those people into one room, having them explain from their use and their applications will be very interesting and educational for the guy who's just coming in for the first time saying, well, I've heard about this, but I don't know whether I want to do it. and that kind of story. So we have a very mixed group. It's much like an organization preceded called IFATS, the International Federation of Adipose Tissue Sciences. So the idea of those multidisciplines feeding off each other and giving each other confidence. And if somebody has a problem and there's a speaker that's discussing that topic, they can always approach that speaker. And one of the great things about the arts is that all of the speakers are easily approachable. So you don't have to just read a paper or just listen to it and try and take it off their slides. You can actually ask the questions and make the speaker defend his position. That's the interchange of that information makes it possible for anybody who's willing to take the time to understand that if they're going to do regenerative medicine, they must document what they're doing. And last year's talk that I gave had to do with the fact that we had to get away from the anecdotal reports, the wonderful case miracles when people are using exosomes or they're using PRP or they're using biocellular, but they don't tell you what the products they actually delivered were. So case responses became non-existent and remain non-existent. And one of the thrusts this year meeting is going to be, how can a small clinic afford to do what is necessary to document the piecework of what they're actually using? Because without the information of what was delivered, you have no information. You don't get evidence with anecdotal stuff. So you have to know what they're doing so we can standardize the protocols, standardize the vocabulary, standardize the communication between the doctors so doctors can understand what the other physician provider is asking about. And so I think it's an opportunity that they will take people at all levels. But there has to be in that meeting, it's a difficult meeting because they have to appeal to the beginners from the very first. I want to see what it means and what does it do and does that apply to me? And then the group that are partially experienced and want to gain more detail and more expertise, all the way to the people who are already past that line, are in scientifically oriented, trying to get you the actual answers to say, what dose is required to gain this outcome? And so database organization within arts is a thing that is an evolutionary thing that's coming. Probably will start this year. And I think that's the beginning of gaining documentation of what we're doing.
I call you the grandfather of regenerative.
Because I'm old?
Oh, you know. Well, you're wise.
I can take it.
You're wise.
I can do it.
Wise does not mean old. My kids call me old, so I don't feel old, but they call me old. So the question I was leading to is how will doctor learn at the summit like about regenerative medicine? Because I know that you've been involved with the summit for a long time. What makes the summits different than other regenerative medicine summit?
I think besides the multidisciplinary background of the talk, of the speakers and the presentations that are being used, and people can judge themselves whether they like what they're seeing or what is accomplished. I would say it's a unique meeting in that it will give something for every level of trainer and trainee, so that you'll have very experienced people with very sophisticated questions. You'll have beginning people that'll ask the basics, and they address both of those as best as any one meeting can. They provide a great basic introduction laboratory sessions for regenerative medicine, which shows how you're going to harvest with microcannulas, how you're going to develop the PRP systems, how you're going to judge the contents of what you're using in the biocellular or orthobiologic mix. There's something for everybody within the context of the program.
There's also a lab on
That's what
on
I was
Sunday.
just speaking about. Yeah,
Yeah,
that one's a full-day lab, and it's useful. It gives you ultrasound portions. It has portions on the harvesting. It has and processing of the adipose-derived tissues, because that's where the majority of the stem cells are. And so I think it's very useful for the beginners to hit the laboratory as best they can.
You're doing something interesting now that is IV regenerative therapy. Can you discuss about that?
At this point in time, the IV therapies, or systemic therapies, are being done basically under a research umbrella, usually IRB or IND, according to the NIH and FDA components and requirements regulatory. And so those things are started there for diseases that don't have cures. There was legislation done in the early 2010s that were taking it towards the right to try, and also from the standpoint of some states will allow in the use of chronic illnesses that have no designated cure. And so those can be done very carefully documented. A full adverse reaction or severe adverse reaction have to be reported. It's a very detailed thing and cannot be varied. That's a structured way that you try to get to a dose response curve that we talked about previously. That idea now is what we are providing that under that organizational thing. I don't think the systemic IV things are going to be for everybody. That's not where you start. That's where you finish. I think what you do is to start, you just document what you're doing when you're doing orthobiologics, for example. Get the cell numbers, get the accurate cell numbers, the viabilities, et cetera, that kind of thing. And also knowing what's your PRP concentration if you're using it in orthobiologics. That's the most important message I'm trying to get across, is you don't need to do the IV systemics to start off with. You have no business doing it without having a team that can deliver a very safe and sterile product. There's some very exciting things coming down the path, and probably in the next 3 or 4 years, that's going to modify a lot of what I'm saying right now, because I think it's going to get more open as more safety is proven. And so the idea of having that as the background and having the core, if the people will learn the basics solidly, the recording solidly, and then accurately report and verify and do follow-up examinations. You don't treat a shoulder or a back or a knee or something and then never see the patient again. If the patient doesn't call back, you're assuming they're cured, which you know that's not a fact. And so there's documentations required, and that the people should, I hope, get the message from last year and this year that is going to be an important feature for those getting started in it. If they get started on the right foot, they will be successful much faster.
I'm glad that you talk about that, because only then can we really advance regenerative medicine and make it less of a wild, wild west. But let's talk a little bit about, and I know that you're doing the IV under IRB, IND, and all approval. How is IV delivery of the MSC helpful in certain cases?
There's two forms of the cellular aspects. One is cellular stromal vascular fraction, which is derived after you've done microcannula harvest. You've micronized it, you've nanofat created, then you digest and separate the cells only. That's one form. The other form is to take that same product, the tissue SVF, the stromal vascular fraction, send it and have it cryopreserved so you can isolate those cells, and autologous, both. They would have to be autologous, meaning other person could not give anything to you, or not safely anyway at this point. I think that those are the two different forms. They do different things. The cellular SVF that is done fresh has a significant potency, because there's a group of cells. In cellular SVF, there's a heterogeneous group of cells that are active. Only about 4 out of, say, 12 cells really are stem-like. And so you can't call cellular SVF therapy a stem cell therapy, because it has supportive cells, has macrophages, has blood cells, has fibroblasts, has a number of cell groups. Whereas when you do cryopreservation, you isolate those cells and you're only giving a mesenchymal stem cell, which is the reparative cell that's scattered every tissue in your body except a couple. Those cells will then home to the site. They'll be drawn to inflammatory responses. They will begin to then attach, and they will then beginning to send and receive intercellular signaling. As that signaling goes on, the body and the site where you're placing it, or where it goes to, will dictate what those cells are demanded to do. and they'll respond on the basis of what the niche or microenvironment, as it's called, what they're asking for.
That's a handful there. Unless you've been doing
Sorry.
regenerative medicine for a long time, you can really follow what he just said. And I just find that sometimes the more you know about something, the more you don't know about something. So how much do you think we know about stem cells and PRP at this point?
We know a ton of materials over the last 15 years. Have been a massive increase in knowledge. I heard the other day the interesting comment that the information in regenerative medicine is doubling every 4 months. Everything known about regeneration is being doubled every 4 months. Now think about that. What does that mean? Doubling. That's exponential growth eventually. And that's kind of where you're getting right now. The flood of information and really good papers and solid background are the things that must be filtered by the people speaking and presenting at the meetings, so that the people that are there are making sure that this is being verified in scientific peer-reviewed papers that are important to understand the concepts.
Absolutely. So I want to ask you this question, and then I see this on your website, the quote. It has become one of the most rewarding experiences of my life to encourage healing while not requiring invasive open surgery. And that's coming from a surgeon trained background.
Not a heretic.
Out there. Can you tell me, can you elaborate on that?
That's another subject that is not narrow, but what I have experienced as with having a long-term background in the reconstructive and aesthetic surgery side, that was very rewarding, of course. But throughout the whole thing was intertwined that every wound I encountered, whether it was my wound or whether it was a gunshot wound or whether it was a car wreck or whether it was just degenerative, all needed to heal. And so now what this has evolved into is that we now have the group of cells, we understand them better. We don't have all the answers. We understand their signaling better. So it's moving from cellular biology towards molecular biology in the verification. So you don't need to become a cellular biologist to know that the professionals, the PhDs and the people that are clinician PhD or MD combinations are going to be able to supply the information. And once you realize that the body can heal a great number of things, it cannot do everything. I mean, for example, in shoulders, if you have torn tendons pulled out of the bone and retracted, you cannot fix that with biocellular or orthobiologic means. But because that's going to require an open surgery with an anchor and pulling it back into place and then let it heal, then maybe the biocellular. So that's an indication where surgery is mandatory. But in a number of percentages, it's mostly breaking down degenerative, aging, torn, stretched, sports injuries, etc., that are being treated, and that having control of the wound healing group of cells and the stimuli that make the cells work together, and they work synergistically, we believe. As they do that, the wounds will heal better, faster, stronger, and won't tend to recur. So that is the reason that it took me to where I am today. And I still do some surgery, but I don't do anything nearly the invasive kind of surgery that I used to do.
Absolutely. So you're going to be teaching at the summit, and so which is wonderful. I've always loved learning from you. And so if a doctor is attending the summit, what question would you like that doctor to ask you?
Depends on the level of the doctor. We should be prepared for answering the basic to the more sophisticated questions. So it's a very difficult question to answer. If you're coming to me and you're just experimenting, putting your toe in the water for the first, I don't expect a question that is very complex, but and they need to do a lot of reading. Also, one of the things that I would love to do is have the participants be provided some basic reading materials from each of the providers, each of the speakers that are published, and let them read about that and ask from those papers, because nobody's going to be able to. Having taught residence and fellowship programs, I guarantee you that you cannot read the other person's mind or what they know or how they understand it. the backgrounds come in so diverse that the questions can be, there's no dumb questions, but there are naive questions and there's very sophisticated ones. And we want to get a balance out of the summit.
What I was heading with that is that what would you like to convey the message about doctors that are interested in learning about regenerative medicine? What would you want that doctor to initially understand? That's
a good question, and it's the kind of question that I think everybody has to come with a basic background. They'll all come from different specialties and different experiences. All their patients are going to be in common because they all have the same problems. And so I would have them prepare and do good reading prior to getting the meeting. One of the strengths of the arts meeting, I think, is that each of the speakers, as I've mentioned before, are readily available to answer questions. Even after that, just contact them by email and reach out and ask your questions. And that the questions will be answered to the best of whoever they're asking's abilities. And if they don't make sense, then to ask it again. We recommend seeking experiences in a clinical sense where they can be trained by one of the really experienced people. And they need to learn to do the protocols the same way, correctly document the same way, and provide evidence into the database for us to, in the future, to be able to say what we can expect from this response.
I did exactly that. When I first learned about PRP, I asked the manufacturer, who's the best person to learn this from? And you were the first name that came up. They said, go see Dr. Alexander if you want to learn how to do regenerative medicine and PRP and fat. And I contacted Dr. Alexander, and next thing I know, I was in his office learning how to harvest fat, and as well as everything that I know now. So learn from the best, because that way you will actually start in the right way. I feel, the technique that you had shown me in 2005, I still use now. I haven't altered that very much at all in probably the last 20 years. Thank you, Dr. Alexander, for being on this episode. And we look forward to hearing your wisdom at the summit. That will be happening on July 30th to August 2nd in Torrey Pines, San Diego. So this is the one of the conference that if you're considering going to one, you want to go to the one to hear from the best speaker in the world who's been doing this for a long time. Plan to attend the summit. It's going to be happening in a couple months. We hope to see you in San Diego.
Thank you very much.